what you might imagine is, where do you go from here? If you look overall at the survival of patients on Admiral, unfortunately, while we showed improved overall survival, we don't see a lot of long-term survivors. And while we can take about a third of patients treated with gilteritinib on this study and bring them to transplant, if you look at the long-term outcomes, they're still not ideal. So the best way to deal with this issue is to prevent relapse or refractory disease altogether and optimize frontline therapy. So the next step for gilteritinib is to move it earlier in disease course in combination either with low-intensity chemotherapy for patients not fit for intensive chemotherapy, or with high-intensity chemotherapy like 7+3, cytarabine and anthracycline. And we've actually completed a phase 1 dose escalation of that approach, and I'm presenting the data on behalf of the other authors, standing in for Keith Pratt's here today to do that. And on this study, what's notable was it was quite tolerable to give gilteritinib at full doses, the very same doses that we use as a single agent with 7+3 induction, including cohorts that had 90 milligrams per meter squared of daunorubicin, which is the highest dose that's used clinically. And this was not only tolerable, but also had a very high remission rate. 93% of patients entered a complete remission with or without full count recovery. And effectively, we did not have difficulty bringing these patients to post-remission therapy. Transplantation and long-term follow-up data will be presented at a future meeting.